Great. Good morning. My name's Edwin Cruz. I'm a neurologist and epilepsy specialist with Mercy Medical Group. Thank you for logging on. I know some of you are off today. And when I was driving to the office this morning, the temperature outside was 29 degrees, which is unheard of in California. And the nice thing about Zoom is that you could log on from your home, in your bedclothes, in your bedroom, right? But you know what they say, you know that you're in California if you consider temperature less than 65 as winter. Speaking of temperature, if you still feel sleepy or cold, I want you to get up from your chair or your bed, stretch a bit, do some jumping jacks, drink from your coffee, and stand at the corner of your room. You know why? Because it's 90 degrees there. Got it? 90 degrees. I know, I'll keep my day job. I have 2 teenagers, and usually if I say dad jokes, my daughter would be rolling her eyes, but that usually helps to get their attention. And now that I know that you're awake and more attentive, I'm gonna move on to my next slide. Go ahead. I don't have any financial disclosures relevant to this talk. Next slide. My topic is about localization of epileptic seizures. Next slide. When we see patients with epilepsy, one of the aims for the evaluation is to find out what part of the brain is producing the seizures. So this involves using the seizure semiology, meaning are there clinical features that would localize the seizure foci or onset to a particular brain region. Number 2 is looking at the epileptiform discharges on the EEG and video EEG. If you have right temporal spikes, then most likely what you have is right temporal lobe epilepsy, right? Number 3, neuroimaging like MRI, PET scan, SPECT, fMRI, WADA testing, and neuropsych testing. For today's talk, we would be focusing primarily on seizure semiology. Next, please. So what I wanted to do for this lecture is to make it a bit more interactive. We would be showing this first video, and I would like you to decide. First, is this a seizure versus non-epileptic spell? Okay. And then we will be explaining the differences as we go along with the lecture. For this one, can I ask everybody to turn on their camera? So what we would do would be, after the video is shown, I'm gonna ask people to raise their hands to vote whether this is an epileptic or non-epileptic spell. I promise I will not single out anybody and ask them to explain, okay? Are you seeing the pictures, Shavika,
Yes.
of our participants?
Yeah.
Okay.
All right,
All right, I'm not. Anyway, okay, so first case, this was referred by one of our community partners, Dr. Al-Muhassani from North Bay. Okay, go ahead. So this is the clinical onset. Notice the movements of the right hand, right face.
hang on, I'm right here. I'm right here. Patient's yelling, clenched up, puffing out her cheeks.
Alert, room 411. Alert, room 411.
All right, this is on the left hand, it's clenched up, she's puffing out her cheeks. Starting to relax her hand now. Heart rate is
Okay, let's pause.
respiration's 20.
Who thinks this is a seizure? Can you raise your hand? I'm not able to see them. Who thinks this is a non-epileptic spell? Next slide. So first question is, do you think this is a seizure? Or do you think this is non-epileptic spell? The second is this the clinical features typical of temporal versus extratemporal seizures? Can we go back to the video? Play it again.
Do you want me to go to the beginning?
Yeah. So these are the typical features that you see with temporal lobe epilepsy. The abrupt change in facial expression, the orolingual mouth movement automatisms. Notice the movements of the right hand. Okay. So stop, then go to the next slide. Next slide. There was a similar patient that we saw last year, referred by Dr. Ruby Ali, who's one of our partners from North Bay. This is a 24-year-old man from Vacaville who's been having seizures since he was 12 years old. He commonly has about 3 to 4 complex partial seizures a month with blank staring, lip smacking, and other automatisms, which we also saw in the previous video. And 2 to 3 times a year, he would have a generalized tonic-clonic seizure. He has failed 6 anti-seizure medications. We know that the definition of intractable epilepsy is failure to respond to at least 2 anti-seizure medication. He was then admitted early last year for video EEG at Mercy General Hospital, and we documented focal seizures from the right temporal lobe with ictal onset from T2 and T4. The brain MRI showed right mesial temporal lobe sclerosis on the MRI. This patient underwent temporal lobectomy on 10/6/21 by Dr. Babitz and Cobb and has been seizure-free since then. Next slide. So this is a typical ictal pattern that we see in patients with temporal lobe epilepsy. In the right half of the screen, you would see the rhythmic spike and slow wave discharges emanating from the right temporal lobe. Next line. Mesial temporal sclerosis is the most common cause of complex partial seizures. This involves atrophy and neuronal loss in the hippocampus. You would see the MRI images showing the right MTS seen in the second patient. This is important to identify because you could have seizure freedom up to 80% in selective patients. Okay, next line, next slide. Temporal lobe epilepsy is the most common form of focal or localization-related epilepsy. Next slide. Looking at the top of the screen, SPS stands for simple partial seizures, which was the old nomenclature. Now the proper term is focal seizure without impairment of consciousness. CPS stands for complex partial seizures with impairment of consciousness or focal dyscognitive seizure. We know that the difference between the two is that in complex partial seizures, there's alteration of awareness. So if looking at these beautiful pictures from one of the neurology textbooks, looking up at can you use your mouse, Rebecca, to point at the right? Okay, the one. So here we see the right upper, the left upper, this one, yes. So we see activation of the right temporal lobe, and usually people would have automatisms like butterflies in the stomach, nausea and vomiting. Then in the second, this one, people would have, with activation of the contralateral hippocampus, people would have alteration of awareness. Then they would usually go into complex partial seizures or second generalized seizures. Next slide. Temporal lobe epilepsy could be further, go back,
There you go.
divided into neocortical or mesial temporal. Neocortical means this involves the lateral aspect of the temporal lobe. Usually it's due to congenital malformations. The aura is usually non-specific. There's early clonic seizure during the seizure evolution, and epileptiform discharges in the EEG would lateralize to the lateral temporal area. Next line. Next slide. In contrast, mesial temporal, go back up one slide. Yeah. So mesial temporal lobe epilepsy involves seizures coming from the medial part of the temporal lobe. Commonly, there's a history of febrile seizures. There's a very characteristic epigastric aura. Patients would complain of nausea, vomiting at the onset. There's usually contralateral dystonic hand posturing of the hand opposite the ictal pattern, and the epileptiform discharges are seen coming from the medial temporal area. Next slide. In terms of the ictal EEG or the EEG recorded during the seizure, the upper figure shows the typical EEG pattern with medial temporal, wherein the ictal discharges is from 5 to 9 hertz. In contrast, if the ictal discharge is slower, specifically in the delta range, like in the lower figure, this would tell you that most likely you are dealing with neocortical epilepsy. This is important to identify because it's harder to do surgical resection if you involve the neocortex, because you would be causing more damage to fluent areas in the brain. Next line. Next slide. So this is second case referred by Dr. Smith, who I see has logged on, and thank you, Dr. John Smith, who's been sending us a lot of great patients from Oroville. This patient was referred back in 2019. He's been having intractable epilepsy with blank staring and lip smacking, and the very characteristic clinical feature is that all the seizures are preceded by an intense urgency to drink water. Okay. So next slide. Oh, sorry. Go back a bit. Okay. So based on this clinical history, do you think this is a seizure versus non-epileptic spell? Then the second question to answer is this a temporal versus an extratemporal seizure? Okay. Next slide. Next slide. So this is called periictal water drinking, which is the action of drinking water during or within 2 minutes of an electroclinical seizure. This localizes the seizure foci to the right or non-dominant temporal lobe. What happens is that epileptiform discharges coming from the medial temporal lobe affects the autonomic nervous systems, especially the hypothalamus, and this causes an urgency to drink water to quench the thirst caused by the epileptiform discharge. Next slide. The patient's MRI shows findings with atrophy in the parahippocampal gyrus and entorhinal area. Next slide. We did the PET scan, and I know it's difficult. But can you hover your? Okay, so going to the other side, the first slide. I'm sorry. Go back. Oh, sorry. Go forward. Okay. So hover to the left side of this figure. Okay. This is actually the right temporal lobe, and if you would compare it, there's hypometabolism of that temporal lobe compared to the left side. And this localizes the seizure foci to the right temporal lobe, right? Next slide. So this patient underwent temporal lobectomy with Dr. Cobb and Dr. Babbitt's in June 2019, and he has been seizure-free since then. Again, emphasizing the fact that we should look for temporal lobe epilepsy because they're quite amenable for surgery. We know that the success rate with temporal lobectomy is like 80%, whereas if it's extratemporal lobe epilepsy, the success rate is less than 50%, even lower. Next slide. This is a very interesting case that I saw with Dr. Dengel in 2016. This is the EEG. I had some problems uploading the bipolar montage, but looking at this, okay, look at this EEG. This is I think the hat band montage, but you could see changes on the EEG. So looking at this, decide for yourself, are you dealing with a seizure versus non-epileptic spell? The second question is, are you dealing with seizures coming from the temporal lobe versus extratemporal lobe? Okay. You see it? Next slide. Next slide. So this is called rhythmic temporal delta. This has the same clinical significance as spike in wave, as indicative of focal seizure tendency, and it localizes the seizure foci to the temporal lobe. Next slide. So this is an interesting case from Mercy Folsom. This was before our group took over the neurology service there. 63-year-old with 3-day history of word finding difficulty in acute mania. Brain MRI, labs were normal. EEG was done. It was actually misread by the neurologist there. Fortunately, she's no longer in practice. Urine traction was normal. The patient was about to be shipped out to a psych facility for acute mania. The hospitalist wasn't satisfied, so they got Dr. Dengel to see the patient who was on tele one call at the time. Then the patient was transferred to Mercy General Hospital to our epilepsy monitoring unit. The patient had 2 general tonic-clonic seizures treated with valproate. We repeated the brain MRI, which was still normal. However, the EEG shows focal left-sided TERDA, temporal intermittent rhythmic delta. In this clinical scenario, one would need to rule out herpes simplex encephalitis, and a spinal tap was done, which was diagnostic. The take-home point about this case is that you need to have a high index of suspicion, especially if the clinical scenario does not fit a psych diagnosis. In this case, the EEG was instrumental in coming up with the correct diagnosis. Next slide. This was another patient referred by Dr. Nidal Khalili like 5-6 years ago. I tried to upload the video. Unfortunately, as some of you may know, early this year, Dignity Health transferred the archiving to another facility, and all the video from December backward last year is now gone. So looking at this picture, look at the patient's hand. I want you to decide, is this a seizure versus non-epileptic spell? Number 2 question is, are you dealing with the temporal versus extratemporal seizure? Next slide. These are pictures from a neurology textbook showing patients having an actual seizure and then rubbing their nose. Next slide. So the question here is, number 1, are you dealing with a seizure versus non-epileptic spell? Number 2, are you dealing with the seizure coming from the temporal lobe or extratemporal lobe seizure? Next slide. This is called post-ictal nose wiping, and it lateralizes the seizure foci to the ipsilateral temporal lobe to the hand wiping the nose. So in this 3 pictures, the patient was wiping their nose with the left hand, and this lateralizes the seizures to the left temporal lobe. This involves ictal or seizure activation of the autonomic nervous system, especially the amygdala, and this results in ictal nasal secretions and causes nose wiping as the patient regains awareness. Next slide. This is a 30-year-old woman referred by Dr. Halima Karim from Woodland Healthcare in 2017. Very interesting case. New onset 6 months of right facial tingling followed by severe pain. She was initially diagnosed and treated as trigeminal neuralgia. However, lately the seizures, the symptoms have been spreading to involve the right arm and right leg, can last 10 to 15 seconds up to 5 to 20 times a day. Sometimes some of these episodes were associated with facial droop. So looking at this case again, I want you to decide, are you dealing with a seizure versus non-epileptic spell? The second question, are you dealing with the temporal versus extratemporal seizure. I was hoping to be able to make this more interactive. Can we have people, you guys, show you, open your camera, see if we could see your faces? I don't see anything. Anyway, next slide. So next slide. So brain MRI shows left parietal lobe glioma. So this patient actually has parietal lobe epilepsy. Next slide. So we know that the parietal lobe is the primary sensory cortex in the brain. So it would make sense that seizures coming from this area would involve primarily sensory symptoms, just like in this case, mimicking trigeminal neuralgia. However, with trigeminal neuralgia, the symptoms should just be in the face. It would never spread to the arms and legs, all right? So you could have positive symptoms like tingling, electric-like feeling. Sometimes there's a desire to move a body part or a sensation of movement. Number three, if it involves the inferolateral parietal lobe, you could have sensation of choking, sinking, nausea, vertigo. So vertigo can be a manifestation, rare manifestation of epilepsy. I've been here for 14 years. I've probably seen just one or two confirmed parietal lobe epilepsy presenting with vertigo. You could also have formed visual hallucinations, especially if the seizure discharge extends into the visual association areas. On rare occasions, it can manifest with pain. Next slide. So case 6, this actually happened to me last year. You're on tele-night call and you're called at 1 a.m. for stroke alert. As you were about to sign out, the ERMD asked for a bedside consult. He had a 8-year-old girl with new onset seizure. They didn't have any neurology coverage, and if we didn't do anything, they'll have to transfer the patient to another facility, which is just like 100 miles away. So I logged on, and this patient has a 1-year history of headaches, which were treated as migraine. In the past 2 to 3 months, she'd been waking up with terrifying dreams together with the headache. Some of these vivid dreams were occurring even when she's awake, and sometimes she would wake up screaming in the middle of the night, which is then it resulted in a seizure, which prompted being brought to the ER. So the question here is, based on this history, are you dealing with a seizure versus non-epileptic spell? Number 2, are you dealing with a seizure coming from temporal lobe or extratemporal seizures? Next slide. So next slide. This patient actually has benign occipital epilepsy. If you would look to the left side of the screen, the upper figure shows what a normal EEG would look like, whereas in a benign occipital epilepsy, you would see the spike in wave in the posterior head region. Rebecca, can you hover your mouse on the left, lower down, go down? Yeah, this one, okay? So those are the typical spike in waves seen in the occipital leads in a patient with benign occipital epilepsy. Onsets usually mid-childhood. There are prominent autonomic symptoms, nausea, vomiting, headache, syncopal episodes can occur. The seizures are rare, but they can be prolonged. And usually treatment is not indicated because the seizures are rare and they usually occur at night. Usually we would just recommend rectal or intranasal benzodiazepines. Next slide. So occipital lobe seizures, we know that the occipital lobe subserves the visual cortex. So you would have visual symptoms. You could either have elementary visual symptoms such as negative symptoms such as scotoma or hemianopsia or blindness in a particular part of the visual field, or you could have positive visual symptoms such as sparks and flashes, which can oftentimes mimic migraine headaches. If the ictal discharge spreads to the association area. In the occipital-parietal area, you could have perceptual illusions such as change in the size or the distance or distortion of the object, such as was described in Alice in Wonderland. Next slide. This is a very interesting case that was actually the first case that we monitored at Mercy General Hospital in 2009 before we got the epilepsy monitoring really functional. The video didn't have the audio. What's interesting about this was that the patient has been going around the community being diagnosed with psych disorder. And she was referred to Dr. Schatzel mainly because they thought she had a sleep disorder, and the patient was referred to me and we did video EEG. Can you play the video? Abrupt arousal, getting up, screaming. Okay, so looking at the video, I want you to decide, are you dealing with a seizure versus non-epileptic spell? Then a temporal versus extratemporal seizure. I think just looking at the video, even without the EEG, we would conclude this is likely a focal seizure, right? The characteristic clinical feature, abrupt onset from sleep. We know that any event that occurs from sleep by EEG criteria has to be organic. It's never psychogenic. So this patient has like 2 to 3 events like this almost every day, every night when sleeping. Always from sleep, never while awake. Next slide. Next slide. So this case is typical of frontal lobe epilepsy. They're usually short duration. They're almost always nocturnal, always from sleep. There's rapid secondary generalization, but the seizures are short. And there's usually abrupt return to normal behavior. There's prominent motor symptoms, the hypermotor movements that we see, like the leg kicking and leg bicycling movements. And a lot of times, unless you're aware of this type of epilepsy, they will be considered psychogenic, because a lot of times when you do the EEG, the routine EEG is normal, all right? So, and also a lot of times because of the prominent motor movements, you could have a lot of muscle and electrode artifacts that just contaminate the EEG and you couldn't see anything. The way to diagnose this, number one, by video EEG, documenting the typical event. Number two, that all of these seizures are stereotyped, meaning that they start the same, end the same, because they come from a specific part of the brain, and there's the way the ictal discharges propagate in the brain, it can cause these stereotype movements. Since it affects the frontal lobe, it would rapidly spread to the motor area, which is why you have a lot of these motor symptoms with the prominent leg bicycling movements. I've been following this patient, and she's doing fine on low-dose lamotrigine. Again, emphasizing the fact that correct diagnosis is the first step to have correct treatment, and in the process, making a difference in our patients' lives. Next slide. Case 7. This actually happened to me a couple of years ago. Your internal medicine colleague texted you a picture of her 7-month baby. Looking at this, do you tell her, A, do not worry, he's just stretching? B, congratulate her that her baby is gonna grow up to be a professional baseball player? C, refer him to pediatric neurologist, which is what I did with Dr. Reina. So in your mind again, answer the question. A, B, or C? Next slide. So this is the prominent fencer's posturing with the seizures coming from the frontal lobe, specifically the supplementary motor area. The clinical features would lateralize, the seizures coming from the contralateral frontal lobe, contralateral to extend the arm. In this case, in the picture, the seizures are coming from the right frontal lobe, front SMA. Okay. So next slide. So this is an interesting case that we saw referred by Dr. Idulji from Woodland a couple of years ago. This, so as you look and listen to the video, again, answer the question in your mind, are you dealing with a seizure versus non-epileptic spell? And whether it's a temporal versus extratemporal seizure. Let's play the video.
Want you to press your button. Okay. All right. I want you to remember an object, a purple clown. Okay. All righty. Okay. Heart rate 99. Respiration 36. 100% on the air. Okay. All right. Okay. Can you tell me what's going on? Can you speak at all? Unable to speak. Okay. Heart rate 122. This right here. Get a blood pressure. Okay. Are you awake? Robin, you awake?
So are you dealing with a seizure versus non-epileptic spell?
All right.
Okay, so let's go next slide. So see, next slide. So we are dealing with non-epileptic spells, right? Next slide. Non-epileptic spells are very common. 25 to 30% of patients admitted to a tertiary epilepsy center with presumed intractable epilepsy are actually diagnosed with non-epileptic spells, meaning that if 1/3 of patients being seen in your clinic with intractable epilepsy, most can be non-epileptic spell. Non-epileptic spells can mimic epileptic seizures, but they're not due to abnormal brain activity, and usually the EEG is normal or non-epileptic form. Next slide. Non-epileptic spells can be divided into psychogenic and organic. Psychogenic includes malingering, somatization disorder, conversion disorder. However, it can also be organic, like sleep disorders, such as cataplexy, movement disorders, such as dystonia, non-epileptic myoclonus. You could also have complicated migraines that can mimic, that can look like seizures. In kids, you could have breath-holding spells. And a lot of times, syncope. A lot of the patients that we see in the clinic who faint, sometimes they have this transient stiffening of the arms and legs for a few seconds, then as they lose consciousness. Next slide. There's clinical pearls that we ask our nurses to look for. The first thing is describe if the eyes are closed or open. Usually with non-epileptic spells, the eyes are consistently closed, while usually in epilepsy, the eyes are open. Next slide. The other thing to look for is asking and looking for tongue biting. Usually with non-epileptic spells, they would bite the tip of their tongue. In contrast, in epilepsy, usually if they would bite their tongue, it's usually the side of the tongue. All right, and these clinical features are hard to fake. Next slide. The characteristic EEG and clinical feature is called limp unresponsiveness, wherein the patient is still unresponsive, eyes closed usually. But if you look at the EEG, it shows the normal pattern of quiet wakefulness. We've been training the nurses at the epilepsy monitoring unit to check this by having them raise both of their arms above their head, then drop it on their face to see. A lot of times patients with non-epileptic spells are able to move their hand in such a way that it would not hit their face. But I always tell the nurses, make sure if you do that, put your hand on top of the patient's face so they wouldn't hurt themselves, okay? So the limp unresponsiveness is a very common feature of patients with non-epileptic spells. The video that we saw, a common term that we use is called fish out of water body thrashing movements. And that usually starts with that, then afterwards, in the post-ictal phase, they become limp and unresponsive. But in contrast to a patient with epilepsy, the EEG is normal, all right? Usually in patients with epilepsy in the post-ictal phase, the EEG would be flat or very slow. As you can see in this slide, you would actually see in the posterior head regions the normal alpha of wakefulness that is characteristic of quiet wakefulness. Next slide. Teddy bear sign is one of the things that we look for. In the video, the patient actually has a teddy bear. Probably in a 5 or 6-year-old, that would be normal. But in adults, certainly it is not. It is an unnatural attachment to an inanimate object. Actually, when I was doing my psych rotation, when I was in residency, especially dealing with patients with adult patients with eating disorders, the psychiatrist would actually make a big deal if the patient has a stuffed toy in their room. Okay, so this is called the teddy bear sign. If you have it, you see it correlated with the EEG, and usually it would go along with the diagnosis. We just had a patient in the epilepsy monitoring unit this week who had a couple of teddy bears in her room, and she's like 39 years old. And the EEG showed non-epileptic spells. So if you see it, that's great. If you don't see it, it still wouldn't rule it out. Next slide. So diagnosis is only possible with simultaneous video EEG. You need the video to document abnormal behavior plus a normal or non-epileptic form EEG. The diagnosis of non-epileptic spell should only be made by epileptologists and only after video EEG. Next slide. Next slide. So this is a very interesting case referred by Dr. Muderas. 2 to 3 times a year, I would see a case that would, humble me and tell me that I still have a lot of things to know. So let's play the video. The patient was in our unit for 4 days. She had like 4 or 6 of these events. Very emotional, eye closure. Look at her hand. So if you've diagnosed this, okay, the EEG was really not diagnostic because there was so much muscle and movement artifacts that all you see are artifacts and you couldn't see anything, okay? So if you diagnose this case as non-epileptic spells, you'd probably be right, all right? Actually, that's what I thought. But there's other clinical features which didn't make sense, like the patients would usually say she has this funny smell, funny taste. So giving credit to where it should go, the credit for coming up with the correct diagnosis actually goes to the neuro nurses, and they do a great job. And this is a case that illustrates it. We could stop that. Let's go to the next slide. Next slide. So this is the same patient later that night. The patient. Next slide. So there's a change from stage 2 of sleep. Next slide. The right half would show arousal. And as you can see, the EEG is contaminated by a lot of muscle movement artifacts. But if you look at the left side, there's actually an ictal pattern that I admit I missed. Can you hover your, okay, the up on the left side of the screen over there? The first two, look at the first two lines, there's rhythmic alpha in the left frontal area. That actually is an ictal pattern, which I admit I miss. I actually looked at several other cases and it was actually there, but there was just a lot of muscle movement artifacts. So the nurse noted that the patient was sleeping, then she started tapping her chest with her left hand, which was actually shown in the video. And this would correlate with that rhythmic discharge from the left frontotemporal area. So this patient has frontal lobe epilepsy. All right. As I said, the credit goes to the nurses for coming up with the correct diagnosis. Next slide. Next slide. This is a case that we just saw in the epilepsy monitoring unit a couple of weeks ago. 50-year-old man with 2-year history of dizziness, palpitation, diaphoresis, feeling of doom. He had 4 events of loss of consciousness with transient right arm, bilateral arm stiffening. He was admitted for 3 days at Marshall Hospital in Placerville in October and had a negative cardiac and stroke workup. The patient continued the event, so the patient was referred to me and he underwent video monitoring last February 15th to the 19th. Next slide. So this is the EEG of this typical event. Next slide. Next slide. Next slide. Oh, come back a bit. One more. You could, do you see again, the credit goes to the neuro nurses. If you would point at the last, the lower part there, where it says event, point at the word event in the middle part, lower part, okay? That's the EKG rhythm strip. The patient actually has 6 sinus syndrome. The patient has cardiac pauses up to 6 to 7 seconds. So the nurse called me and I said, oh boy, 6 seconds, what does that mean? So I got a hospitalist consult and they were excited about it. Then they called cardiology. And Dr. Ariana came in, they did implanted the pacemaker that same day. I actually saw the patient in the waiting area as you go through security screening at Mercy General Hospital, and he was with his family. And they were so happy. He was doing great. He didn't have any symptoms 2 weeks after. The wife and couple of his friends was there, and the patient was saying, oh, he did a great job, you know. And they were pounding my back, and I was trying to avoid shaking hands with them because of COVID. But if you think about it, the nurses the credit really goes to the neuro nurses and neuro staff. And we're actually very lucky to have that. Next slide. So this is one of the patients that we saw years ago. This referred by Dr. Han from Marysville, 39-year-old with intractable epilepsy since he was 3 years old, had normal prenatal and postnatal history, no families with epilepsy, mild mental retardation, developmental delay, failed multiple meds. EEG shows seizures that were lateralized but poorly localized to the left hemisphere. Next line. Brain MRI was normal, but we did the PET scan and it shows left temporal lobe hypometabolism, indicating that the seizure is coming from that area. Next line. The patient was admitted for phase 2 video EEG with intracranial electrode array to localize the seizures and also so we could do brain mapping. Next line. There were seizures documented coming from the left amygdala, and that shows the rate figure. Next line. This is actually the EEG in the middle part of the figure. In the right side shows the ictal discharge coming from the left amygdala. Next slide. So we did cortical brain mapping, and the black dots indicates areas with language deficits in the left hemisphere when stimulated. The good news was that this patient underwent a left temporal lobe epilepsy, temporal lobectomy, and the resection margin was actually in front of where the deficits would be. Next slide. So he underwent temporal lobectomy in 2014. There were no post-op deficits. He was actually seizure-free since the surgery. Last year, he came to my clinic because he had some auras, which occurred after stopping his meds and drinking alcohol. Pre-surgery, he was having 3 to 4 seizures a month. Next slide. I never tired of showing this picture because it really shows the big difference we could make in our patients' lives. Next slide. The success of the epilepsy center at Mercy General Hospital would not be possible without great staff with the EG techs. Next slide. The nurses. Next slide. My neuro staff at the MMG Midtown Clinic. Next slide. And finally, I have a couple more slides, but in interest of time, are there questions or concerns? Any comments at this time?
I have a question. When you remove the temporal lobe, does the patient have different characteristics, I guess, personality, any
Not
changes?
really. Before we even consider surgery, patients would go through an extensive testing. We'll start with a comprehensive neurological history and physical exam, EEG to localize the seizure foci, MRI to find pathology that we could resect, and usually they would also undergo neuropsych testing. So basically, we would choose patients who would, there's a sort of a criteria, because the aim is to have 0 seizures with 0 or minimal neurologic deficits. So for instance, in some of the cases, like the young woman who had the parietal lobe epilepsy with the left parietal glioma, we did brain mapping, and actually it shows that the language center as well as the hand center is actually being encroached on by the tumor. So obviously, resective surgery wouldn't work. What happened with that case, for instance, was she was referred to UCSF, and they did stereotactic. They did stereo EEG, and then they were able to do partial resection. Fortunately for her, it was turned out to be a grade 2 glioma, and like 7 years after that surgery, the patient's still doing well, and actually seizure-free, being followed in my clinic. So, especially with temporal lobe epilepsy, if you do temporal lobectomy, there are very few, if any, neurologic deficits, at least in selected patients. It's harder if you have a seizure foci, for instance, in the frontal lobe or the parietal lobe, wherein the seizure foci may be encroaching in areas that are functional. Like, for instance, if you have seizures coming from a part of the brain that controls the hand area, then surgery probably will not be a good idea. Okay. But usually, what's being done nowadays, that in most epilepsy centers, they'll be doing intra-op monitoring just before surgery is done, to really make sure that you are not going to take out eloquent or functional areas in the brain. Any other questions?
I would also comment that although there is a few % risk of worsening neurocognitive function and mood with temporal back to me, there's about a 10% or so improvement in attention and concentration and mood in patients, typically because you obliterated their seizures.
Good point. Any other questions? If not, thank you for your kind attention. And we will go back to our normal day. Hopefully by this time, the weather would have improved. And thank you very much for logging on. And Dr. Armour would take over in a few minutes for the neurology division meeting.
I'll launch the meeting now. Thank you.